Thank you so much, Dr. Escobar, for your very kind introduction. You know, it's such a pleasure to be back here at the Texas Heart Institute. And as you know, today I'm going to talk to you a little bit about I think, the frontiers of electrophysiology, which is primary prevention. In electrophysiology, primary prevention is really not something that we have a good handle on, and I think it holds our field back quite a bit. And so what's desperately needed, I think, is to have a restorative method to restore electrical conduction within the heart. And the point of this is to hope to stop arrhythmias before they start in the first place. And so today I'm going to talk about some exciting data from our laboratory that really shows us how we can use new materials to facilitate electrical conduction within the heart. So here's an outline of the talk today. And so I'm going to start out by talking a little bit about electrical conduction and reentry. And then in the second part of the talk, we're going to go over some of the unique properties of carbon nanotube fibers and how these fibers have properties that may have beneficial functions in the heart. I will then talk about some of our recently published data on carbon nanotubes, how they pick up and deliver electrical current within the heart across scar and across the AV junction. And then finally, I'll show you some exciting new data that is under review right now, where we show that we can use these fibers in specific configurations in the heart to prevent arrhythmias from stopping in the first place. So first, electrical conduction and reentry. So every fundamental biological process in the heart, and indeed in the body, relies on conduction and transduction of electrical currents. Whether it be cognitive, sensory, motor, or visceral functions, all of these functions in the body rely on efficient conduction of electrical impulses. If there's a traumatic or degenerative disease that process that interrupts this electrical conduction, it can have devastating effects in the central nervous system and in the heart. And I think one of the reasons for this is that because we're dealing with highly differentiated tissues, these tissues don't naturally regenerate themselves. And so specialized tissue like the heart, the vasculature, and the central nervous system, they just don't regenerate to restore electrical circuits. Importantly, in the heart, impaired myocardial conduction is the underlying mechanism for reentrant arrhythmias. And reentrant arrhythmias are one of the major types of arrhythmias in the heart. So reentry is one of the most common causes of arrhythmias of any type. And we commonly see this in cardiology. And we see this in our heart failure patients. We see this in post-MI patients, where the onset of monomorphic VT is one of the most common causes of sudden cardiac death in Western societies. And really, VT is a final common pathway to death from a variety of causes, no matter what the input is, whether it's myocardial infarction, heart failure, congenital heart disease, et cetera. All of these disease processes can end in monomorphic VT, which precipitates sudden death. And I would argue that VT is treatable at this point. So you can use a catheter or you can use a medication to try to reduce the recurrence of VT or the incidence of VT. But at this point, it's not necessarily fully preventable yet, right? So even a defibrillator, we put them in for primary or secondary prevention, but the arrhythmia has to show itself in order for the shock to be delivered, right? And so I would argue that ventricular tachycardia is not 100% preventable at this point. And we can think about other reentrant arrhythmias on the other side of the AV junction, atrial flutter. Atrial flutter, especially left-sided complex atrial flutter, is very common post-cardiac surgery, and along with atrial fibrillation, it's the #1 cause of arrhythmias post-surgery. And sometimes this can be very complex. So if it's left-sided, you're searching for multiple anchor points, you're crossing over from right to left. And it can be difficult to treat and be associated with long ablation times and multiple anchor points. And so atrial flutter also has a very high stroke risk. So in general, reentrant arrhythmias are a major problem that we deal with in electrophysiology. And I think it's really helpful to try to understand the underlying mechanisms of reentry. Because if we understand the underlying mechanisms, then we can start to get to the point where we could hope to prevent reentry in the first place. So just to kind of go over some of the mechanistic concepts on the tissue level, when you have a boundary, and a boundary can be anything really, it could be a scar, or it could be a valve, or just slowly conducting tissue. So when you have a normal sinus rhythm that's coming towards a boundary, what happens is the electrical depolarization wave traverses that boundary, and then on the other side of it, there's a collision of wavefronts, which leads to extinguishing of that signal around the boundary. So in normal sinus rhythm, you normally don't have these risks of reentry. But for reentry to happen, there's actually two main criteria in order for that to happen. The first one is unidirectional conduction block. And that's the idea that at least one of these limbs is unable to conduct. And it's unable to conduct possibly from a PVC or refractory tissue. But for one reason, the limb is unable to conduct on one side. And then the second criterion would be conduction system slowing. And conduction system slowing usually occurs around the edges of a scar where fibroblasts are involved. And so if you have these two conditions, which is unidirectional conduction block and conduction system slowing, that can precipitate reentry around a boundary such as a scar, and that reentry is associated with both morbidity and mortality. So often reentry is a lot more complex than this simple image that I showed here. So sometimes reentry can happen around different wavefronts, and this is an image from one of Rod Tung's papers showing a critical isthmus that was mapped endocardially and epicardially in a patient with ventricular tachycardia. And I think this is a nice representative example of how in electrophysiology we usually target an isthmus as a critical Achilles heel of an electrical circuit. And here's kind of a schematic of what that might look like. And so in general, we try to target an isthmus with ablation. And sometimes it's not quite that simple because, as Dr. Birkeland showed in some beautiful images this morning, sometimes there's multiple different channels and scars can be complex. And sometimes these different channels compete with each other for electrical primacy. And so we sometimes try to treat exit and entry points to a scar, let's say in ventricular tachycardia, but then the next least path of resistance is some unexpected pathway that we didn't know was going to occur. And so catheter ablation of ventricular tachycardia is commonly done, and it's successful, but there are some limitations in how much we can burn and to our knowledge of where these complex channels are. So despite our best efforts as electrophysiologists, at the end of the day, with ablation, we're fighting scar with more scar, and thus we're reshaping the scar to be less arrhythmogenic. And it's been documented that during these left-sided ablations, it does cause a coagulum, which can go to the brain and has unknown, responses as well. And the question in all this is, we're fighting fire with fire, but are we actually addressing the mechanism for how this reentry occurs in the first place? And like I said before, the mechanism of this is primarily slowing of myocardial conduction. And so did we actually treat the mechanism by ablating? So I'd like to use that as kind of a transition to speak about some nanomaterials that have some unique properties that may be of use in the problem of reentry. So to approach this problem of delayed conduction within the heart, we need a material that's conductive like metals, that is flexible enough to handle the movements of the heart, and is strong enough to withstand the heart's forces. And additionally, we need this material to be non-toxic because we're hoping for long-term implantation. The unfortunate thing about metals is that they're pretty stiff, and the myocardial tissue interface with this material is actually pretty rigid. And there's a pretty high impedance step up to get from metal into the myocardial tissue. And so there are some limitations with metals. If you think about surgical sutures are able to appose different tissues, but they don't really facilitate electrical conduction between one piece of tissue and another. So I think an important thing to do is to try to think about how new materials could be a conduit to bring together both the performance issues that are needed in cardiac surgery or with EP procedures, but also conductive properties of metals that we would desire. And so turning to nanomaterials are typically engineered on the atom-to-atom or molecule-to-molecule basis. And when we turn to nanomaterials and think about them for their use in cardiology or electrophysiology, we're typically thinking about molecules that are on the 10 nanometer to 100 nanometer range. And oftentimes you can engineer these molecules to be macroscopic assemblies. And so one example of this is nanoporous gold. So nanoporous gold is a really interesting engineered gold substance in which it combines the ductile properties of gold metal and then also the stiffness of other types of metals. And so depending on how you apply a current to these nano gold materials, they can actually become more ductile or more conductive or stiff if you need them to. So this is just an example of how by engineering something on an atomic level, it can actually have macroscopic effects that are more than would have otherwise been expected. So over the last several years, it's now probably over a decade, I've had the distinct pleasure of collaborating with really two great scientists, Dr. Matteo Pasquale and Dr. Mehdi Rouzavi, in the nanomaterial space. Dr. Pasquale is the chair of chemistry at Rice, and he's been manufacturing carbon nanotube fibers for 10, 15 years plus. And my friend and mentor, Dr. Mehdi Rouzavi, is, I trained with you at, here at Texas Heart, and we really had some really interesting conversations that led to, first cell experiments and then experiments in tissues with these fibers that led up to large animal studies. And it's really been an amazing experience. And so I'm very indebted to my team for the data that I'm going to show you today. So about the time that I met Matteo in 2012, I think, he had just published a paper, it was 2013. He had just published a paper in Science that demonstrated a new manufacturing process for the development of carbon nanotube fibers. So carbon nanotubes are microscopic structures, and you can see they have this birefringence that you can see in panel A under the microscope. And carbon nanotubes have been shown to be electrically conductive and have really unique properties as an electrode. But in order to be able to use this in the heart as a suture, you need it to be a macroscopic structure. And so Dr. Pasquale developed a manufacturing process where you actually hard bake these in acid, and then you extrude them through a spinneret, which is a structure. Trying to pull up, there we go. A spinneret, which is a structure in which, I don't know if you can see this, but you see the fiber coming out of that spinneret, and then you can actually scale it up to be multiple fibers that come out. It comes out into an acetone bath, and then it's rolled up onto a drum. And this fiber, it feels like, almost like you're holding a human hair in your hand. It's about that diameter, and it's extremely strong, and it's electrically very conductive. And this is just an example from his work, just showing how In panel A, the comparison of these fibers versus other carbon fibers, that it has unique electrical and thermal conductivity that's much higher than other carbon textiles. In panel B, you can see that in comparison of this fiber versus other metals, how the tensile strength it's a very strong substance versus other metals, and then conductivity in panel C as well. So the fibers have both deformability, tensile strength, and electrical conductivity that really makes it a really high performance material for surgical suturing. So if you look at these fibers really closely with an electron microscope, what you see is that the fibers are really densely packed. So in panels A and B, you can see electron micrographs just showing the highly aligned orientation of these fibers. In panel C is an azimuthal scan, just showing that alignment, that that there's fine peaks showing they're highly aligned. And in cross sections in D and E, you can see that there's very little space in between. So really what we're looking at is a crystalline structure. And if you think about it, a metal which conducts electricity, right? I mean, it's a crystalline lattice. So essentially these carbon nanotube fibers are so densely packed and highly aligned that they form a crystalline lattice that has that conductive property as a carbon electrode, just like metals are an electrode. Another really cool thing about this material is if you dope it with iodine or gold or another ionic molecule, that it increases the conductivity. And so this is an example of doping of these fibers with iodine or acid, showing that it increases the conductivity by several orders of magnitude. And another really interesting demonstration of this is just, if you can see, if you can hallucinate with me, you can see that this light bulb is actually suspended by the carbon nanotube fibers, which are 40 microns in diameter, but can also conduct the energy required to power the light bulb. So this is a really nice demonstration of how the fibers can conduct. So I'd like to move on now and show you some published data of how we've used carbon nanotube fibers as a conduit to pick up electrical charge from one part of the heart and to deliver it to another part of the heart. So given that these fibers have really amazing conductive properties that hadn't been previously described, we wanted to see if we could actually connect different parts of the heart. And we performed a really interesting set of experiments in sheep. And so what I show here is kind of the experimental setup of what we did. We used decapolar catheters, and we used 4 of them to make kind of like a picture frame. And this picture frame is kind of our referent electrodes to be able to sense what's coming from the middle of the picture frame out to the periphery. So the picture frame is kind of our reference here. And in the middle, we have pacing electrodes that are put in the center of the heart. And we actually decided, let me preface this by saying that the surgical setup here is we did these experiments in sheep, and we performed a left lateral thoracotomy to expose the heart. And so these are epicardial measurements. So getting to the scar, we actually made a horseshoe-shaped scar in the left ventricular epicardium. And the reason why we created this horseshoe-shaped scar is we wanted to create anisotropy in our pacing. Now, what does anisotropy mean? That means that there's a definite and defined direction. So when you pace in the middle of the area of interest, it has a defined direction that it's going to go out from that pacing spike. And so the opening of the horseshoe is at the 4 o'clock position. That's the direction that we wanted the electrical conduction to go in. And at about the 10 o'clock position, which is the heel of the horseshoe, that's actually the slowest area where a signal would propagate out. And so we decided that the best demonstration of these fibers improving conduction would be to put it at the heel of the horseshoe, or the 10 o'clock position. This is a photograph of what that surgical setup looks like, with the decapolar catheters creating that window, and then the CNT fibers spanning a horseshoe-shaped scar. And on the right is just a photograph of our carbon nanotube fiber, and you can see that the way that we were able to surgically attach this to the epicardium was we tied it to a curved proline suture needle. So here's actually the data output from the experiment, and we have 4 conditions here, and these conditions are used throughout this published paper and then also the paper that we just sent for review. So there are 4 conditions. The first condition in red is baseline. And so what this means is that this is the baseline condition without any scar creation. We just put the electrodes there, we pace, and then we see how long it takes for the paced signal to get out from the center to the periphery. And on average, it was about 26 milliseconds. Now, after we made the horseshoe-shaped scar, we had a delay of conduction by about 150%. To 41 milliseconds. And in black, you can see after the radiofrequency-induced lesion on the epicardium, the time that it takes to get out to the picture frame walls is much longer. However, when we attach the carbon nanotube fibers to the area of slow conduction, we actually pulled in the conduction either physiologically or superphysiologically, however you want to interpret it. But we pulled in this electrical current to near normal levels. And then in the 4th condition, we completely removed the fiber and replaced it with silk. And we use silk as a negative control because silk is made of carbon, but it's not conductive, or at least not very conductive. And so that was our negative control for the experiment. So just to show you a little bit more data, these are polar plots, and what a polar plot shows is the time that it takes for, to go from point A to point B in each of the conditions in basically 360 degrees. And so, like I mentioned, the time that it took to get from the center of the lesion out was about 20 or so milliseconds for each of the different positions around the horseshoe-shaped scar. In panel G, you can see that there's that brown horseshoe-shaped scar that kind of gives you a reference there. And in black diamonds is how much the scar prolonged conduction time. In panel H, you can see that with attaching the fibers at the heel of the horseshoe, you actually pulled in the time to near physiologic levels. However, in panel I, when we replace those carbon nanotube fibers with silk, you actually do not get that restorative benefit. So we interpreted from this data that the carbon nanotube fibers are able to pick up electrical current from the inside of the scar and deliver it to the outside of the scar and basically pick up electrical conduction and make it more efficient. So here's just another way to graph the data, showing that if you're away from the carbon nanotube fibers, like electrodes 8, 9, 10, or 1, 2, 3, that you actually don't get that benefit, but you can see the reduction in conduction time at the position where the fibers actually connected, which is electrodes like 4, 5, and 6. Okay, so we thought this was really exciting, and we wondered, can we do this in other types of electroanatomic boundaries? Right? So if you could hop a scar, could you hop the AV junction? Because that might have use if you could engineer a way to conduct from the atria to the ventricle. That could have future potential use. And so what we did in a mouse model is we chose the right lateral AV junction because this is usually the area where accessory pathways show maximal pre-excitation. And essentially, we attached the carbon nanotube fibers from the right atrium to the right ventricle. And you can see in the electrograms on the left that pre-implant you have a clear defined P wave and a clear defined QRS wave in the EKG. But after the implant, you see a couple interesting things. You see that there's a delta wave. You see that the P and the QRS become indistinct. And you also see that the morphology of the QRS has flipped. So all of these are indicators of ventricular pre-excitation, which is commonly found in the Wolff-Parkinson-White syndrome. And on the middle and the right panels, you can just see that the proportion and the number of beats that are pre-excited are pretty high. We got over 80% of the heartbeats that were generated naturally to be pre-excited. Now, some people might say, well, aren't we trying to fight pre-excitation? That's not therapeutic. I'd agree, this is a proof of principle that, for us it was important to show that you can connect electroanatomical boundaries. And I think that the AV junction, obviously we're not going to be tying this across the AV junction without engineering some latency into it if we wanted to make a synthetic AV node. Here's another example of, in a mouse model, how the mouse was in normal sinus rhythm at baseline, and then we injected alcohol into the septum and caused AV block. And then we tied the nanotube fibers across the AV junction and showed that we recruited the AV conduction about 80% of the time. It wasn't perfect. These fibers were not insulated, but nonetheless, it really showed us that the AV conduction was actually possible across the AV junction. And so to prove this further, we actually scaled this up to a sheep model. And the sheep model gave us some distinct advantages because you can actually put catheters in different parts of a sheep heart a lot easier than you could like a mouse. And so we did this experiment, which I think was also really interesting. First of all, we took a decapolar catheter and we put it in the coronary sinus of the sheep, which straddles the AV junction between the left atrium and the left ventricle. And in this sheep, the basal rate was about 90 beats a minute. And so we started by pacing the ventricle about 3 centimeters below where we wanted to attach the fibers. And we sped it up to about 125 beats a minute. And in this sheep, there was really no synchrony between ventricular conduction and atrial conduction when we were pacing in the ventricle. However, in panel A, when we added the carbon nanotube fibers, we actually had the signal jump up the fibers from the ventricle to the left atrium and then go from laterally to medially, as you can see here. And these are the electrograms on the right that show that when the fibers are connected in the upper right electrogram, that you see a one-to-one relationship between ventricular depolarization and atrial depolarization. And when you take the fibers off, then there's dissociation between the ventricles and the atria, proving that the fibers alone were enough to cause that synchrony. And I wanted to spend just a few slides, it's a little complex, so I just wanted to spend a few slides kind of showing this, that after a ventricular pacing spike, as you can see here, then you have depolarization of the ventricle, outlined in the V in the electrogram, and then depolarization of the atria, shown by the A here. And then again, pacing, depolarization of ventricle, and then the atria. There's also, we use this electrode to prove that only the fiber, which was laterally placed, was the cause of this conduction, right? Because somebody might say, well, wasn't it the AV node? I mean, that you didn't ablate the AV node here, right? So how do we know that that wasn't the case? Well, if you look at the order of the atrial waves, you see that it only went lateral to medial and not the other way around. So that disproves that the AV node actually would have been the cause of this V to A conduction. And this is just some mathematical modeling of this showing that, that the fibers were necessary and sufficient for this conduction, and that it only occurred, that this conduction only occurred with the fibers on and not off. So we were interested in the mechanism of why would this occur. And so we wanted to characterize this tissue materials interface a little bit better. And so we explanted some bovine hearts and performed spectroscopy on the left and voltammogram experiments on the right. And I think you can appreciate on the left that the impedance of this fiber on the tissue, on this bovine tissue, was, and this is a logarithmic scale, so it was about 2 orders of magnitude less in the fibers. And then in the voltammogram on the right, you can see that the capacitance of the fiber is actually much, much higher than a referent platinum electrode. So what we think is going on is that there's just, the impedance is very, very low for this tissue materials interface. And because it's very low, it's very easy for electrical depolarizations to go up into the fiber, and the fiber has high capacitance, so it's very easy for it to conduct along its surface. And really, carbon nanotube fibers are really great at gaining electrograms. So here's an example of where we just compared carbon nanotube fibers in blue to decapolar catheters that are attached to the epicardial surface. And basically what we found is that the signal-noise ratio is favorable versus these decapolar catheters, but it's 1,000 times smaller surface area. So it's a really great electrode at actually picking up electrical signals on the heart or on the skin. So I think these are actually electrograms that I did. So good news is I'm in sinus rhythm, at least in 2019. And you know, if you were to just hold the fibers in your hands, this is the kind of, in blue, the kind of electrograms that you get. And this is versus commercially available EKG electrodes. So one future potential application of this is if you could sew this into a shirt or a patient's hospital gown, can you take the EKG from their clothing and it be as good, if not better, than putting the stickers on their chest, which, as many of you know, causes such a terrible rash and discomfort for the patients. So that's also a really, you know, practical application for patients, not just in a surgical setting. And these are just spectral analyses of the fibers, just showing that the quality and the definition that you get in the EKGs just from holding it in your hand is just as good as the stickers that you have for the Holter monitors or telemetry monitoring. And the ability to discriminate the T wave is actually pretty good, so no double counting, which I think is important when you're trying to figure out, you know, does this patient have arrhythmias or not? So moving along, in terms of toxicity studies, we want to make sure that if we implant this, eventually someday in humans, that it's not toxic. And so we did a round of biotoxicity studies where we injected the sera that was exposed to the fibers in panel 1, or we actually injected the fiber itself, IP, panel 2. And in panel 3, an example of actual muscular implantation in the hind limb of a mouse for at least 90 days. And then we performed histology studies and basic autopsies in these animals. And essentially what we found is no significant changes in weight of the animal, no significant changes in weight of any vital organs. As you can see in the weight of the animal in panels A and B, and then the weight of the organs in C and D. And then we had a randomized blinded histopathologist that looked at different organ systems, including heart, liver, lungs, and kidneys, and there was no observable toxicity. And here's just examples of slides from each of the tissue at the implantation site showing no significant inflammation there. So from this data, we conclude that the carbon nanotube fibers restore myocardial conduction across epicardial tissues. They have a unique material tissue interface with low impedance, high conductivity, and they're very flexible and very strong and are suitable as a surgical suture. They can bridge the AV junction, they can bridge scars, and at least up to 3 months they're not toxic. So we thought this was really interesting, and that brings me now to some exciting new data that is just off at review at Circulation Arrhythmia. And the last part of this talk, I want to focus on the observation that carbon nanotube fibers can prevent arrhythmias by changing the electrical flow across the scar. So given that we proved that these carbon nanotube fibers could pick up and deliver electrical currents across the heart, we wanted to see if this restorative effect could change, the electrical flow such that it would be anti-arrhythmogenic. So the design here is that if you have a boundary like a scar, could you just connect different poles of the scar and have them depolarize simultaneously? And if that's the case, if they could depolarize simultaneously, could you have an antegrade wave and a retrograde wave that collide and actually snuffs out the arrhythmia? So in other words, this could be anti-arrhythmogenic. So we initially tried this by making scars in RF scars in the ventricle, but unfortunately there was a high fibrillation rate, so we decided to migrate to the atria, the right atrial appendage, so that the animals would survive long enough so that we could make important measurements. So this is our surgical setup of how we performed the experiments in the right atrial appendage of sheep, epicardially. So in panel A, you can see we took a duodeca or 20-pole catheter. We actually bent it on itself to form a circle with a diameter of about 4 centimeters. And this is one of our sensing electrodes and pacing electrodes. In panel B, what I'm showing is we have a carbon nanotube fiber, and the ends are denoted by arrowheads. And in the center of that, we put an insulating tape in there just to make sure that there was no charge dispersion into the solution in the setup. And then at the bottom are curved suture needles, which we use to implant across the scar on the superior and inferior poles. And in panel C, this is just how we implanted the fiber into the tissue. And very similar to the last paper, we had 4 conditions that we were testing. So baseline, just without any scar, and you have the duodeca catheter that's encircling the right atrial appendage, as you can see in panel D. In panel E, you can see that we ablated a 4 centimeter area on the right atrial appendage, and so that asterisk just shows the scar where we ablated. And then in panel F is the implantation of the carbon nanotube fibers, and panel G is where we took those fibers out and replaced it with negative control silk. Here are the electrograms that we got from that, and it's a little complicated, so I want to take you through it. On the top, you see 3 electrograms that are just surface ECGs that we got from the limbs of the animals. And then that duodeca catheter, that 20-pole catheter that I showed you, below that is the electrograms that we got, the bipoles from that catheter. And what we would do is in 9 sheep, we performed 6 pacing attempts in each of the 4 conditions. So we had a total of 216 observations from our pacing experiments. And at baseline, after atrial pacing, so what you don't see on the left of the page is that there's a pacing train. And then in these 3 asterisks in blue, those are the last 3 pacing spikes before you stop pacing. And then, just like in bowling, when you release the ball and then you see how many pins you knock down, in electrophysiology, when we're trying to induce arrhythmia, it's the same thing, where you deliver a pacing train and then you stop and then you see, did I induce the arrhythmia of interest? So these are the last 3 beats of the atrial pacing train. And then typically with the baseline condition, it just reverts back to sinus rhythm because there's no scar there. There's nothing to re-enter. And then in panel B, you can see that after the same type of pacing attempt, the animal goes into atrial flutter. And you can see the flutter waves in the duodecapolar catheter. And then on the top, on the surface ECG, you can see where the QRSs are. So there's about 3-to-1 conduction from this atrial flutter down into the ventricle. And that's with the RF-induced scar. When we bridge the scar from superior to inferior, kind of the 12 o'clock to 6 o'clock position, after atrial pacing, typically we would get sinus rhythm. And sinus rhythm was the predominant arrhythmia. We induced flutter about 28% of the time, and I'll show you a quantification of that in the next slide. But in the fourth condition, silk negative control, typically we would get atrial flutter. So these are just the electrograms showing you the usual output after atrial pacing. And here's the quantification of that. So on the left, you can see atrial reentry incidence. So again, no reentry before scar. About 76% of the time with a scar, we could induce reentry, but we knocked that down to 28% with the flutter, with the carbon nanotube fiber. And then with silk, we did not have that restorative effect. If you look on the right, you can also see when we did induce flutter, how long was the flutter duration. And not only was incidence, but also duration a lot lower in the carbon nanotube fibers versus the scar or the silk. So we thought this was pretty spectacular, but we also wanted to understand the mechanism of why would this happen. And so we took really detailed measurements of the time that it takes to get from the top of the scar for that electrical impulse to get from top to bottom. And so what I'm showing you here is each of the 4 conditions that we talked about. And then we have calipers in blue, and you can see that those conduction times below. And you can see that the conduction time increased with scar and decreased with the fiber, but not the silk. And then this is just quantification of that, and it's pretty involved, but just to say that on the left, we're showing the velocity, how rapidly that signal got from the top part of the scar to the bottom part. And the inverse of that on the right, which is the conduction time. So if it's slower, it's going to take longer and the time is going to be greater. And so we just show basically that the fibers, the mechanism of how this happens is they actually speeds up myocardial conduction across the scar. This is very similar data, just showing the same in a pace condition. So the last slide was sinus rhythm, and then this is just with pacing. Because remember, we induced the flutters with pacing. So I think it's important to also make these measurements with pacing. And essentially, we showed that we can pull in the conduction time with the carbon nanotube fibers versus silk or versus scar. So one of the challenges that we encountered when we were doing these experiments is that in this sheep model, it's really hard to have sustained flutter. The sheep would have flutter for 30 seconds, 45 seconds, a minute. But in order to make a really detailed local activation map, it has to be in incessant flutter, basically. And that's difficult in our model to show that. But we did have an additional sheep that had incessant flutter around this boundary. And so we used this opportunity to make an LAT map. And on the top panels, A and B, you can see how there's reentry. You can see that it goes from early to late, basically red to purple. And you can see that boundary between red and purple, which we always look for in electrophysiology. And then a proof of that with our duodecapolar catheter, where you see sequential activation of each electrode on the right. And then in the bottom, this data is after we connected a carbon nanotube fiber across, and that white line that's coming down diagonally is a visual representation of where that fiber was connected. And you see a couple interesting things here. You see that the the superior and the inferior pole are activated simultaneously. They're both red, which I think is pretty interesting. And then you see that the wavefronts that are curving around, are starting to collide. It didn't terminate the arrhythmia in this animal, but we did see collision of wavefronts. And you can see that not only in the LAT map on the left, bottom left, but in the bottom right, you can see fusion of waveforms. So we're getting manifest fusion of these waveforms. And so what that means is that these fibers are causing simultaneous activation of different parts of the scar, and it's starting to have a fusion of waveforms. So we found that that was really interesting, and I think supports the mechanism of what we're doing here. Finally, to try to understand how termination happens, we turned to a collaborator, Lena Tolkacheva from Minnesota. She does a lot of in silico modeling of reentrant arrhythmias, and so we asked her and her group to help us model what these carbon nanotube fibers might be doing. And based on some of our measurements, she showed that if the box represents a scar or a boundary, and then the colors represent the wave of depolarization, that as that wave of depolarization travels clockwise, and you can see this from A, B, C, D, E, F, that there's a retrograde wave starting in panel D that comes backward and collides with the antegrade wave in F. So these fibers, there's a lot of evidence that they support the collision of antegrade and retrograde wavefronts, and that's the mechanism of termination of arrhythmias, and probably why we had such a low incidence of atrial flutter after pacing. So I think these fibers are really interesting. I think they have a lot of potential applications in the heart. We need to do more studies, more chronic implantation studies, to show that if you implant these and then come back to the animal in 3 months, that it's still going to be anti-arrhythmogenic, right? Because, fibrosis can set in, other things can interfere with that response acutely. And, I would love to be able to show this in the ventricle as well. So we're working on some post-MI models that might be better than RF ablation. So that's another future direction for us. Other areas that I think could benefit from enhancing electrical conduction in the heart would be left bundle branch conduction. Right now we're doing left bundle branch pacing, which is a really exciting approach, but another exciting approach could be reconstituting left bundle branch conduction without the need of a pacemaker. So that's one thing that could be interesting. And then the real goal would be, if we could create a synthetic AV node, that would just be really amazing, I think, because, to be able to replace a pacemaker for AV conduction, I think would be really spectacular. But one thing that we need to engineer into these fibers would be latency. So right now they act more of like an accessory pathway than they do, and they don't really have nodal properties. So by engineering some semiconductors in parallel in the circuit, we could hope to possibly make a synthetic AV node that actually has some latency that acts more of like a native AV node. I'm deeply in debt to members of my own lab, especially Ken Lizama, who did a lot of these surgeries, to Francisco Gonzalez, to Mehdi Rezavi's lab, Abdu Elgalad, to Brian Greet, Matthews John, Stephen Yan, and Matteo Pasquale were all major contributors to this effort, so I'm deeply in gratitude to them. I'm grateful for funding for this project from the VA, from the NIH, and other sources at UIC. And again, thank you for having me. It's such a pleasure to be back. So great to see so many friendly faces and family members in the audience, and I'd be happy to take any questions.